Positioning Lesson 3 covers hand, wrist, and forearm. The upper extremity from the fingertips to the elbow joint. 13 minutes covering the standard projections, the essential special views, including the scaphoid view, the common fracture patterns, and the evaluation criteria for each projection. 3 standard hand views. PA hand. The hand is placed flat on the IR, palm down. Fingers slightly spread so they do not overlap. Ish 40 inches. KVP. 50 piet to 60 piet. No grief. Sin anatomy. CR. Perpendicular to the third MCP joint. The third metacarpophalangeal joint, which is the knuckle at the base of the middle finger. Demonstrates all 5 metacarpals, all 14 phalanges, and the 8 carpal bones. Lateral hand. True lateral, thumb pointing up. The fan lateral technique spreads the fingers superimposed over each other in a fan pattern so the phalanges do not obscure each other. CR. Perpendicular to the second MCP joint. Demonstrates foreign bodies, volar plate injuries, and dislocations. The lateral thumb is always included, essential for evaluating the thumb CMC joint. Oblique hand. The hand is rotated 45 degrees medially from PA, fingers parallel, not curled. CR. Perpendicular to the third MCP joint. Best view for metacarpal fractures. The metacarpal shafts separate and are seen individually without superimposition. 3 standard wrist views and 2 essential special views. PA wrist. Wrist flat on IR, forearm pronated, fingers extended. CR. Perpendicular to the mid-carpal area, centered on the lunate. SID 40 inches, KVP 55 to 65, no grid. Lateral wrist, true lateral, radius, and ulna must be superimposed. CR. Perpendicular to the radial styloid. Demonstrates lateral carpal relationships, essential for diagnosing perilunate or lunate dislocation. On a true lateral, the capitate head should sit in the cup of the lunate, which sits in the cup of the distal radius. Oblique wrist, 45-degree lateral rotation, demonstrates the lateral carpal bones. The scaphoid view. PA with the wrist in ulnar deviation. Ulnar deviation straightens the scaphoid from its naturally oblique position, elongating it and allowing the waist to be seen without foreshortening. This is the most important supplemental wrist view for suspected scaphoid fracture. Add a 20-degree proximal angle toward the elbow for even better waist visualization. The scaphoid waist is where 80% of scaphoid fractures occur. AP forearm. Elbow fully extended. Palms supinated, facing up. Both bones visible without overlap. Radius and ulna separate and parallel. Ishi 40 inches. KVP 60 to 70. No grief. CR. Perpendicular to the mid-forearm. Must include the entire forearm on one image, elbow joint to wrist joint. No cropping. Lateral Forearm. Elbow flexed 90 degrees. Thumb pointing up, true lateral. Radius and ulna superimposed in true lateral. CR. Perpendicular to the mid-forearm. Must include elbow joint to wrist joint. 6 common fractures of the forearm and wrist. Colles fracture. Distal radius with dorsal displacement. The classic dinner fork deformity on the lateral view. Most common fracture in adults. Mechanism. Fall on outstretched hand, fush. Smith's fracture. Distal radius with volar, forward displacement. The reverse of Colles. Sometimes called a reverse Colles. Galeazzi. Radial shaft fracture plus disruption of the distal radioulnar joint. Always look at the DRUJ when you see a radial shaft fracture. Monteggia. Ulnar shaft fracture plus radial head dislocation. Always look at the radial head when you see an ulnar shaft fracture. Nursemaid's elbow. Radial head subluxation in children. Usually from a yanking mechanism on the arm. Not typically visible on X-ray. Clinical diagnosis. And scaphoid fracture. The most commonly missed wrist fracture. Frequently invisible on initial X-rays. Snuffbox tenderness after a fush fall is a scaphoid fracture until proven otherwise. Avascular necrosis, AVN, is the major complication if missed because the blood supply to the proximal pole enters distally. 5 positioning and evaluation standards. Finger projections. PA. Finger flat on IR. The remaining fingers can be propped on a sponge to isolate the finger of interest. CR. Perpendicular to the PIP joint, proximal interphalangeal. Oblique. 45-degree rotation. Lateral. True lateral with other fingers move clear. PA hand evaluation. All 5 digits and metacarpals fully visible. Third MCP joint at the image center. Soft tissue visible around all margins. MCP joint space is open and not foreshortened. No rotation. Metacarpal shafts symmetric in width. PA wrist evaluation. Distal radius and ulna. All 8 carpal bones and metacarpal bases visible. No rotation. The pisiform should project over the middle third of the scaphoid on the lateral border. Lateral Forearm. Distal radius and ulna superimposed. Capitate in the cup of the lunate, lunate in the cup of the radius. This alignment is critical for diagnosing perilunate dislocation. And technique. KVP 55 to 65 for all hand and wrist work. Low KVP produces short scale, high contrast, which shows bone trabecular detail clearly. No grief. Remove all jewelry before the exam. 3 hand, wrist, and forearm questions. The answer is B. PA wrist in ulnar deviation, the scaphoid view. Ulnar deviation straightens the scaphoid from its naturally oblique position, projecting the waist without foreshortening. Scaphoid fractures are frequently occult on standard views. Snuffbox tenderness after a Fuchs mechanism with a negative initial radiograph should be treated as a fracture with MRI or repeat films at 10 to 14 days. The answer is C. The CR was angled rather than perpendicular to the MCP joints. When a hand is truly flat and the CR is strictly perpendicular to the third MCP joint, all MCP joint spaces should be open. An angled CR strikes the joint surfaces obliquely and foreshortens them. They appear closed. An oblique hand would show different anatomy rather than closed joint spaces specifically. The answer is C, distal radius with dorsal displacement, the dinner fork deformity. The Colles fracture is the most common adult fracture. The lateral view shows the wrist angled backward, the classic dinner fork or bayonet appearance because the distal fragment has displaced dorsally. A Smith's fracture is the opposite, volar displacement, reverse dinner fork. Lesson 3 complete. You covered PA, lateral and oblique hand, PA and lateral wrist with carpal bone anatomy, the scaphoid view and why it matters, AP and lateral forearm positioning, 6 common fractures including Colles, Smith's, Galeazzi, Monteggia, and scaphoid, and evaluation criteria for each projection.